OsteoSignal Episode 7. This is OsteoSignal with Neal O'Neal, a podcast exploring how your body's natural design connects with osteopathic science. Translating complex signals into practical insights so you can truly thrive.
My name is Neal O'Neal. I'm an osteopathically minded manual physical therapist. All that to say that I've treated patients for years and years and have taken information and knowledge and scientific reasoning and the latest research and tried to turn that into an improved way to treat the human body, and maybe treat the human body in ways that not many people do. So with that being said, I'd like to open up this podcast. We want to answer some questions from some of the actually students who have taken classes, but of course we have a few different realms here.
Hey, joining Neal, I'm Brent Mayberry, and I'm just here to maybe help Neal clarify his answers and make sure that what he says makes sense.
Perfect.
Something like that.
Yes. Okay, so the first question I had from a student, she is a licensed massage therapist, and she had a question about a 65-year-old male had left knee surgery, partial replacement with titanium on the medial side of the knee only. And the doctor had ground off the damaged bone, apparently maybe osteophytes or arthritis, and put in a plate that glides on a disc, which is how knee replacements work. She's worked on the client once 11 days post-surgery, and he did okay. She treated his pelvis, his sacrum, his leg, and tried to drain the lymph out of his legs, worked on his upper extremity and neck, but avoided the working on the leg, internal and external rotation, and didn't treat the leg too much because the gentleman was still quite swollen. So our question goes on: when using the walker for recovery, he was able to walk without rotation in his leg. Without the walker, he externally rotates the left leg when walking. The question is how to best treat when I see him a month after his first appointment with me. Do I avoid the knee until swelling is totally gone? Am I okay to fix the external rotation now? She's kind of saying, I haven't had some of the other classes, and referred back to those. So the real question is, how do we treat patients post-operatively? And I had taught a class on the pre and post-surgical knee and hip because people have questions about this. First and foremost, patients actually need to start having their leg treated immediately, or their surgical site treated immediately. Now, that doesn't mean that you go and grab onto where the actual opening or the actual wound, surgical wound is. Obviously, you're not going to go and do that because we don't want that to open. But you want to do the work right up to and around that scar, including on the prosthesis, because when they make the cuts, so for example, for a total knee replacement or even a partial knee replacement, they cut open the bone. And that bone now is, the bone marrow is exposed, and that's an irritant to the body. So the body's going to have an immune response. That's often why people's knee, in this case, would be really hot, or their hip, or whatever it is they've had operated on. Plus, there are going to be some sutures in there, depending on how deep and what other problems they had. So immediately, it's very important to start working on the entire leg, the entire body. I mean, that's kind of the osteopathic idea, is that the whole body is important. And so in keeping with that, we definitely want to open up all the lymph drainage pathways. But even getting right down to where that bone marrow is being exposed, there's going to be a healing of the top of that bone so that new bone will start growing in, much like a scab on your skin, kind of the same sort of thing. So it's important to help that process along immediately, going around making sure that the prosthesis doesn't have, that the skin isn't sticking down, or the layers of tissue aren't sticking down to the prosthesis, et cetera, et cetera. Mobilizing the scar from up to an inch or half an inch away from the scar, making sure that the skin and subcutaneous tissues can move around the knee appropriately. All that to help lymphatic drainage, to decrease over immune response to the prosthesis, to the knee, to that whole structure. Because the longer that inflammation is there, the more that it sits there, the more of an inflammatory and hyperimmune or inappropriate immune response we're going to have. And that's really just going to retard healing and hold off. So traditionally, like physical therapists, they'll say, oh, hey, we have this knee. The doc said we got to get it straight. We got to get it bent. We got to push on this. We have to start beating on it. That is the most ridiculous thing you can do, because the thing that limits range of motion in the knee is the edema and the swelling. So the answer to the question is you have to immediately start working on that and let the patient know. So this is also for patients who might not know, like, oh my gosh, I should be seeing my therapist right away. Whether that, and so oftentimes the doctor's like, don't go to PT because I don't want you doing those exercises and they're going to push you too hard for so many weeks after the surgery. However, if you're a manual therapist who's going to do these other techniques, then you need to see that patient as soon as possible, because from the very early on, the more you can get the system and the fluid to flow, the less hyper response they're going to have. The sooner they get back to function. That's certainly something we see with a lot of clients. And then I tell people, stop worrying about the range of motion. If we deal with the fluid, the range of motion naturally comes, because the surgeons will often tell patients, well, gee, that's funny that you don't have the range of motion, because when I finished putting your new knee or new hip or whatever in, we did a full range of motion evaluation to make sure that it didn't stick anywhere. And your range of motion was amazing. And it's like, well, yes, because it didn't have edema yet. That, and the other aspect of it that I like to talk to people about is like, look, if I turn off your computer, how easy is it to update your software? You can't update the software when the computer's off. If the patient is out, if the patient is under anesthesia and out, their neurological system is not aware of what's going on and cannot, get feedback as to how it should react. So when the doctor puts the patient out, manipulates the joint, and then brings it back from being under, that doesn't mean you've upgraded the software. That just means that he went and did more damage to the knee, that now the neurological system and the immune system are going to come back and go, oh my gosh, there's even more damage here. So that's hugely problematic. And again, don't force range of motion, deal with inflammation, and the range of motion comes. Because at the end of the day, it's the fluid flow in and out of the area, appropriate fluid flow in and out of the area, and appropriate immune response. It's maybe more difficult for people to truly understand that, look, your neurological system, there's two parts to it. There's the hardwired nerves, right? And then there's the liquid nerves, otherwise known as hormones, immune cells, macrophages are going to come in. All sorts of things are going to come in there. And if they get the wrong signals because there's too much edema or too much concentration of, say, there's too much concentration of stuff that was left over when the prosthesis was outside the body is going to have a bad response to that. So your job is to help as things break down, as proteins from, say, there was a bacteria. There's no way there wasn't a bacteria and a fungus and a virus on that prosthesis. There's almost no way that you can't have something, even just the open air, going in there and dropping stuff inside the body. But the body may have already dealt with it, may have already killed and destroyed whatever that was, but the proteins are sitting there. Proteins are called antigens. And if the immune system continues to see this antigen sit there, even though it's been that its whole source, the whole fungus or the whole bacteria has already been destroyed, you're going to continue to have a ramped up immune response, which means more inflammation, less range of motion, less function, longer healing time. So you can see this order of things that you're really getting in there to start cleanup immediately, and to help the cleanup team inside the body, aka the immune system, deal with everything that it needs to deal with, but then wash it out of there and move it out so that you can appropriately have an appropriate response to this surgery, which is the patient getting back to function and getting back to their activity as soon as possible. Okay, so I think that kind of covers that. Autumn, do you have any? You probably have experience with that, with patients coming in soon after their.
Yeah, I just left one actually. She came in, she has a compression fracture into the tibia and tore the meniscus and then blew the ACL. And, she had just gotten back from PT yesterday, and they're like, we want you to be able to bend your knee, and we want you to be able to extend your knee. And we treated away from the leg first. We were treating in the upper second rib, like the thoracic and the outlet, because it's got to all go up through there. Made sure the midline could drive things, that the diaphragm wasn't stuck on the back of like the hip flexor area, that kind of stuff. And then made sure she had really good internal hip rotation on both sides. And the inguinal ligament stuff was just open, and she just drained right up, shrunk right up. And when we put her brace back on her, she had to tighten all the straps. So, she's much happier. She's like, oh, I mean, and it was painful, sure, but she's draining now, and the comfort is much better. So,
And she's going to get her range of motion back much quicker that way rather than forcing
yeah,
it, traumatizing the tissue and creating more edema.
yep.
Right.
Yeah, because she could recruit her muscles. She could bend twice as much as she could before. She's still not at 90 that they tell her she should be, but you're like, well, not with how you've treated it. She can't treat it. She can't bend it that far, but it was already doing better. So, yeah, but it just shrunk right down.
Yeah. Yeah. Perfect. Okay. So I have actually a second question from the same student. We were teaching an Barrel Arbuckle class on how to treat children and adolescents, and actually all humans with cranial uh, uh, cranial osteopathic techniques. One of the things that she had pulled in was like understanding that as the child is developing in the initial stages, the occiput is the most important bone. But after that's kind of set and functioning and has gotten its relationships appropriate, then as the child continues to grow, the the function of the sphenoid becomes first and foremost. And so her question was, when what Arbuckle endorsed treatment would you focus on for a 5-year-old who has spent years thumb sucking? So the answer to this question is going to be kind of complex because we are dealing more with that sphenoid. Uh, and of course, with any patient that we're looking at with head, neck, and problems, head, face, jaw, mouth, nasooral pharynx, and thumb sucking is going to be something that the child is putting that thumb there because they need some kind of stimulation, or they're in some ways self-treating. Since the whole body and Arbuckle's whole point was really accentuating venous sinus drainage of the skull, and the venous sinus drainage in the skull is, remember, venous return. It's the veins getting deoxygenated blood out of the brain area to allow oxygenated blood to come in. So certainly some of the things that we want to do, and you almost always start with making sure that the temporal bones function properly. Do they internally and externally rotate, or are they locked? Again, the occipital bone has to work first. Oh, no, excuse me. If the occiput doesn't work, and remember that Arbuckle's whole point really was that the dural membrane system is a bunch of guy wires that attach the bones to each other and keep them in a relationship to each other. But in that through the labor and delivery process and obviously birthing, that those bones are designed to come apart and to move into separate areas, and that what we call whole bones in an adult are there's multiple pieces of those bones in the baby. So, for example, the occiput is 4 pieces of bone. So you have to be able to look at that and then understand that. So the treatment comes on that. So of course you have to understand Arbuckle's treatment approach for that. But to kind of get into any, like, even if you don't know Arbuckle's technique, what do we want to look at with that child? Well, obviously we're looking at what are all the cranial bones. They're the traditional cranial bones, and those most important we call the sphenobasilar symphysis, which is really occiput, sphenoid, right? And then we say, okay, well, there's that. That the other one would be, say, the ethmoid, the temporals, all those basilar portions of the occiput or of the brain case. So we have to make sure that those are all working together. And then, of course, in a 5-year-old, we're saying, well, now the sphenoid function is obviously a problem. That somewhere early in life, if this baby's been a thumb sucker, this child's been a thumb sucker from the beginning, we're definitely going to start at occiput. We're going to definitely go into temporals, get that all to function properly, but then get right into sphenoid and understand, like, why are they putting their thumb into basically the roof of their mouth, which is where the maxilla and the palatines are. So how do those maxilla and palatines attach to the ultimately be driven by the sphenoid and function properly, such as this child doesn't feel they need stimulation there all the time?
Are they doing that because of pain, Neal?
They're going to be doing it for a number of reasons. It may be pain, or at least not pain, but discomfort. Um, More than likely, though, they're also doing it for kind of emotional reassurance, kind of like a child who has inappropriate sensory feedback, so that they either need lots of feedback or no feedback, like they freak out when they have too much feedback. In this case, this is a self-soothing technique. So there's something about their limbic system that's not functioning right. Again, back to the sphenoid and the sola turcica, where the pituitary gland is, and how we pump fluid into and out of the midbrain, and making sure that the limbic system functions and the hypothalamus functions properly. So there's going to be a lot of interaction here. But obviously through the face, this child is finding some comfort. And so what you want to do is go in and say, well, what can we do to establish normal function in that area so this child doesn't need to put pressure in there to feel soothed? And obviously that would be removing venous fluid, getting the pumping action of the brain and face to function appropriately. So we're going to start with looking at the clavicles, right? Half of the clavicles are the back half of the clavicle is a cranial bone. The scapular spine is a cranial bone. The hyoid is a cranial bone. Okay, so those are the first three places we're gonna start. Is we're gonna say this is a 5-year-old child. We're no longer dealing with a newborn. We probably have a leftover problem from a newborn, and at that time, all these bones were separate bones. And at 5, some of those are still separate bones. So you still have to be very gentle, of course. But you're also thinking of that guy wires, that the dural membrane connects these things, and though even the deep investing cervical fascia is part of that whole process. So the clavicles have to work with the hyoid, and T4 and the scapula have to function together. Those have to function with the occiput, right? You think about C1, C2, half of C3 has to function with the scapular spine and with the clavicle and the hyoid. And then so you keep building these rings of function, saying, okay, and then how does that assist me in dealing with C3, C2, C1, occiput, the lateral aspects of the occiput, and then how does that function with my face? So there's a test called the Fulford face test, where one grasps either side of the frontal bone and then holds that steady while you grasp first the nasals, or you're trying to get the ethmoid, but the ethmoid's kind of deep medial on the nose there. So into the eye sockets a little bit, and you gently shift, hold one hand steady and try to shift the other one medial and lateral, left lateral, right lateral, to see, is there a stiff side? Then you go down to the zygoma, then you go down to the maxilla, and you do these same tests. And you'll say, oh, okay, in relationship to the sphenoid, I have stiffness with this bone or this bone or this bone or this bone on the left or the right. Now, Arbuckle, that test comes directly out of Arbuckle's work, because her first test is to test the back of the head, the back of the skull. And what we're looking for is the two lateral portions of the occiput, not the basi-occiput, but the lateral pillars, if you will, of the occiput. So below the inion, below the external occipital protuberance, the back part of the bone there, you have to test that back part of the bone. So even if somebody's doing this at home and they know nothing about cranial, they can do these tests. They can hold their baby's head in their hand such that they have the underside of the head. And then they can grab the frontal, the eyebrow bones, and gently move them side to side while they hold their backhand stiff.
Can you bring your hands up just a little bit more, because we could see one set of fingers?
I forgot you guys are watching me. Okay, awesome. Let's see this. Okay, so if you just hold the skull under your, and I don't have one handy, hold the skull in the back of the baby's skull in your hands, and then the eyebrow, what we call a lateral canthus, just try to gently, very gently, see, do those shift easily, or does one feel just like a rock? Then that means that's locked. So you can do that. So Arbuckle's first test, she did that, right? Now, the second part of this is that also with that hand held on the occiput, how does the baby's clavicles work in relation to that? How do their scapula work in relation to that? So you can hold that. So Arbuckle's test was hold the occiput and move the scapula, move each scapula, move each clavicle, move the hyoid, right? So you're holding that the whole time, saying, if I stiffen the occiput, do my other bones work in coordination with it? And of course, we go into then, if you turn around and the baby's facing away from you and you hold their occiput and you say, does C3 move independently? Does C2 move independently? Does C1 move independently? So Arbuckle went through all those stages, and she said, now, and then by testing the occiput to the sphenoid, you say, oh, does the back half of the skull work with the front half of the skull? Then you can continue that treatment or that assessment. Now just hold this frontal bone, which is going to hold on to the sphenoid, and test the ethmoid, test the zygoma or the facials or the malars, and then the maxilla. And remember, the maxilla go clear up here to either side of the nose, so you have quite a bit of bone to grasp onto. You can also do that by putting a glove on and going in the mouth and checking the palatines. So the roof of the mouth looks like a cross. Let's say that the teeth are here, right? So there's this cross, and these are the maxilla, and these are the palatine bones. So right at the back of the throat where the hard palate ends and you get into the soft palate, and people will start gagging if you go too far back there. So there's ways to check each one of those places. Like I said, the one test is called the Fulford test, but really it's just one small portion of Arbuckle's entire evaluation of that area, saying where in this entire structure. So for example, because this is a thumb sucker, you would want to go into the roof of the mouth, or say you've determined that the ethmoid is not working. It's stiff on one side here, and that you notice that, okay, if you try to stabilize that and then move the hyoid, that it also makes the hyoid very stiff, and there's a real restriction of the baby's throat's ability to move, or the 5-year-olds. So you want to make sure that those two move in rhythm with each other. So first you might treat it off the sphenoid, then off the zygoma, then off the maxilla, then off the hyoid, then off the clavicles. So you keep following this, and then the other part of it is you might put your finger in the roof of their mouth, right? Is it the maxilla on the inside where that cross is, either the maxilla, or is it the palatines that it's stiff with? Why is that baby sticking that thumb in there, right? And so the roof of the mouth, to put pressure on there to support the function of that area, right? To self-soothe. And so obviously that baby needs, or that kid needs something to happen there appropriately that's not happening. And typically, the sucking action itself is going to tense that area. So it's going to be a pumping action. Sucking is going to be it's a pumping action, not only for fluids down through the throat, but also in the face and brain case are getting, sucked in and released, sucked in and released. So they're actually draining their own skull. You have to replace
And that's amazing.
Yeah. Right. I mean, once you kind of go through it, you go, oh, they're just trying to drain their own skull. Why don't we help them with that? And then right in between that cross, of the palatines and the maxilla, at the back part of that is where you can influence the vomer. So you can do a vomer pump technique, or what's called a mother's milkshake by some. Now, remember, a 5-year-old, as a baby, Arbuckle was really against putting your finger in their mouth because it's just too easy to do damage. Because again, the bones are all in pieces. There's nothing really connected. By 5, there may be a little better reason to put your finger in their mouth. I mean, of course, remember, extreme gentleness is important. Okay. Now, the other part of that is you can also extend that Fulford face test to include the mandible. The mandible is a little bit more loosely connected, but it is part of that sucking mechanism. The hyoid is really a tongue bone, if you will, right? So you have 2 tongue bones, the mandible and the hyoid. So both of those have to work with each other, and they have to work with the face and head and neck. And if they don't, that baby, when they're eating food or swallowing or doing anything else, or even just at rest, they're not draining their own skull. So that's really, the question was, what would Arbuckle say to do it? And from my reading of Arbuckle, that's what I would say would really be where she comes at it from.
I think it's really neat when these kids come in and they, their parents come in and say, well, they have a concern with this or they have a concern with that. And then, but with the techniques that you taught a couple weekends ago, it's been so much easier for me to be able to feel that, where you can isolate and play those bones off of each other through those membranes that she drew out. And you can be like, man, I mean, and then you really can provide a customized treatment for that kid at that time, because you're like, oh, they're stuck here, they're stuck there. And then they're going to grow a little bit. Next time you see them, they're going to be stuck in a different spot, or, maybe stuck down again. And so being able to understand those relationships a lot better for me has been really great, because I've got kids that are depressed. I've got kids that are, have had head injuries. I've got, adults that have had injuries and stuff like that. And you go back through these membranes and you're like, I can really find that stuck spot. And I don't know what got it there, how long it's been there, but you can take that pressure off, and it changes their behavior and it changes their mood. And it, like that limbic system stuff. It's amazing the results you get.
It is amazing. And that's just it, is that, some people would hear you say that, Autumn, and go, "Oh my gosh, that's fantastical," but seems unlikely. And the whole point of it is if you understand the physiology of it, of like, look, first off, if the brain case is not getting used up blood out of the area, you can't bring new blood into the area to let off nutrition and oxygen. And so those neurons will be depressed. They won't do their job. And if the neurons can't fire together and interact appropriately, then the neurological function is depressed. Well, behaviors are neurological function in different groups of parts of the brain, particularly the limbic system, the hypothalamus, thalamus, um, the amygdala. We can go through structure after structure, saying if those structures cannot coordinate their firing of neurons and interact like an advanced brain, then you get depressed behaviors like depression, like alterations in behavior, that you'd say, well, this child's very shy, or this child won't do this, or they're very sensitive to stimuli in the area. Like they can't dampen down stimuli in the environment so that they don't
Yeah.
overreact to it.
Right. They do fine until they get in a certain situation, they shut down.
Yeah, and they
Things
shut
like that.
down. And then
Yeah.
of course, we look at them and go, "Oh, why are you doing this? You're just being bad, or you're misbehaving," and not understanding that there's a biological, mechanical, organic cause of this that doesn't require medication. That doesn't, uh, require all this outside counseling or this, that, the other. That if I mean, not I'm not saying that stuff can't help, but if they don't have the underlying function, how can you ask them to function at the level that society expects humans to function at when they don't have the same brain functioning that most humans have or should have?
Hmm.
So yeah,
Well, and
exactly.
I know we talked about this last week too, but my son that came with me to the class and we worked on him, we haven't put his brain braces, the wire back in. And I've asked him, I said, well, how do you feel? And he's like, I just feel so much better. If I had to choose, I'd rather have, you know, a little bit of crooked teeth right now, even though he's a teenager, and feel better, because he's much more calm. He's got much more of a sense of humor. He tolerates stress better. And before, I kind of, as a mom, because I'm a mom and a therapist, right? I kind of have juggled well, he needs to learn to coping skills. He needs to learn to be able to handle these situations. And yeah, but that wasn't enough. And now I'm like, oh man, he was stuck there, right? And
Right.
so having that understanding of like, oh my gosh, well, it wasn't because he wasn't listening. It wasn't because he wasn't trying.
It's not
It's
because
just
he's a bad
that
kid.
wasn't the
Yeah.
handle. No, no,
Yeah.
that wasn't the handle. It
It's
was,
not
you
because
got
you're
to
a
take
bad
the
mom.
physical stress off.
Right.
Thanks.
Yeah. No,
I'm
you're
trying.
not a bad mom. He's not a bad kid. Yeah,
Right.
exactly. It's that situation. And the more that you treat him and work with him, mechanically, physically, then those brain structures integrate and fire together and learn and respond appropriately and accordingly. So exactly. I mean, it's amazing. And I'm
Hmm.
glad to hear he's doing so well. That's awesome.
Yeah. And now we're just using it on all the other patients that come in that need it too.
I know,
But it
right?
is neat. And to some degree or another, it helps people be better versions of themselves. Their structure and function, the osteopathic way, right? They influence each other. So
Right.
it's neat to see.
They self-regulate better because they're in control of their internal environment, and if they can control their internal environment, they can deal with the external environment much better. And that's just physiology. That's called normal physiology. And the problem with like say allopathic medicine is that they're always focused on how do we treat a disease. If you approach every
Hmm.
problem from how do we treat a disease as opposed to uh, how do we restore health and proper function, then you only come up with medications. You only come up with helmets. You only come up with things that fix a symptom. Like let's treat this symptom. Let's treat that symptom. And that's very problematic. As you said, like the osteopathic minded or the osteopathic approach is to look at the whole. But this isn't just like, oh, I'm holistic. It's no, we're literally talking about how does the brain case affect the brain and its ability to drain? Like what role does the brain case hold in this entire thing and affect the function of the neurons?
Yeah. And then like that little boy with the second thumb, like, why is his limbic system acting that way? Why is he feeling that way? Right. And,
Why does he need to do
it's
this?
exactly. And then you can that gives you that clue to like, this is where I need to go hunting. So
Right. And that's
that's
just it.
neat.
That's the real point is where do you go and find a way to alter that course? Not, hey, we'll just throw this on top. And like you said, I'm a parent, you're a parent, we've all done these things. You're going, I just don't know what to do with this kid. I just wished I'd known more of this stuff when I was younger, but that's why
Yes.
we're here to teach everybody else, and hopefully they can make use of it while their children are young, or even on themselves. Like you said, we have patients of all ages coming in, and we're going back and going, "Oh my gosh, I can see how your head and neck were impacted by the by labor and delivery. We can see those injuries still there. There's still patterns."
When I've been treating myself while you're talking, going, "Oh yeah, I got to check that out." So
That's right. I got to do it. I was sucking my thumb the other day. No, got to do my highway.
I had a little bit of anxiety. No.
Right.
Yeah.
Exactly. All right. Oops. Where are we at? Okay, we got time. Perfect. I think we have time for one more question. Let's where did she go?
This is great, by the way, even for a non-practitioner like me.
Okay, that's awesome.
Am I
Appreciate it.
talking too much?
No.
Oh, no, perfect.
Okay.
There we go. Okay, so she had another question. Okay, so next patient, she says she has a patient who's a female in her 60s. Her first appointment, she did her scan exams. This student did her scan exams of the patient, and she ended up having to work on the pelvis, the sacrum, the neck, thoracic lumbar adjustments. She did some Bennett's. Bennett's approach is about visceral to visceral functioning, getting organs and their timing of each other, saying, "Hey, I've digested this." The stomach says, "Hey, I've digested this food." Pancreas, it's your turn. And then lower down in the small intestine saying, "Hey, stomach, I have room down here. You can send more stuff down. So tell the pancreas to get on it." So that kind of signaling. So she did some Bennett's. And okay, so did Bennett's and worked with the vagus some. And then she did something with the xiphoid. I'm not quite sure what she means by that. And right quadrasumborum. Afterwards, there was still pronounced side bending of her upper body when she walked to the right due to her repetitive motion when she works on clients. She must be a massage therapist as well. There were other improvements within the first treatment for sure, but I will. No. The question is how to best treat. What should I do next time? Like, do your scan exams. There you go. Here's the thing. Go through, do your scan exams, treat your patient. They're going to come back. Do your scan exams, treat them. You don't know what the next treatment's going to be. And for you to plan what the next treatment is going to be is actually fairly ridiculous because the patient's going to go out and do all sorts of things you couldn't possibly imagine. How many times have you had?
Okay, well, just for fun, I do that at the end of almost. I think, next time I see them, I'm probably going to do this.
You
I
definitely
am
say,
never, ever right. But it's just kind of fun for me in my head to be like,
I got to work on this. I got to work on that. I got to work on that. I think that's planning, but that's not like, okay, I have my whole treatment already mapped out. It's like, well, I have a plan to work on these things, but then they're going to come in with what they have, and you're going to go, okay, I wanted to get to this, but let's get them here. And ideally, what you're going to do is as you go through your scan exams and get there, you're going to come right up against the same problem again. You go, oh yeah, this is that problem they had last time. Ideally, you would get there more quickly the second time around than the first time around. But ideally, you would come back down to those same things. And that's what you're going to see. It's this pattern recognition for therapists. Like what keeps coming back? What's not changing and why? And that's the question for therapists. Okay.
That's the fun part of doing our work.
Yes, it is. Okay.
It's like doing puzzles all day long.
It is puzzles all day long. And it can be kind of difficult because, and that there might be the best answer for this question saying, look, don't get too caught up in worrying like, okay, you do your scan exams, but ask better questions. Find out what the patient's doing. Why is this coming back? I mean, is it a repetitive pattern? Is it something they do? And they go, oh yeah, every time after 4 hours of pickleball, my plantar fasciitis blows up. You're like, well, first off, you can't tolerate 4 hours of pickleball. So how far into pickleball before your plantar fasciitis starts to flare up? Why make it about 2.5 hours? Okay. So,
yes.
And next time come in, go play pickleball for 2.5 hours and then come in here. Don't go for 4. Things like that. So yeah, I guess that question it wasn't a full question, but it led us somewhere anyway. So that's worthwhile. That's really how
when we try and use these things, we don't do recipes on people.
Yeah,
I
they're
mean, I
not
don't.
rush fees.
I've
They're
never
not
given
set
the same treatment
programs.
to anybody. Like, I've never given it to the same two different people, and I've never given the same treatment to the same person twice because
Correct.
they're never the same. So, and you don't have to take the stress. You just rely on those scan exams where you go, okay, well, let's test everything and see where I start. Then you go mess around in there and kind of like the zoom in part that I always talk about, right? Like zoom in and find out, well, why isn't that working right? And then, feel around what attaches here, what sticks here. And then you fix that and you got to zoom out again and go, well, now how does that work with everything? And then, okay, well, this doesn't work. Then you got to go hunt around. Sometimes you're going to spend the whole treatment in that first zoom in spot and be like, well, hopefully that lets some things up, but we can't go any further with the other stuff until that gets out of the way. So it depends, but that's how we can provide like how we want to be treated, right? The golden rule. I want to be treated for what I need the most thing at that time. I don't want you to treat the person that came in before or the person is coming in later that you've been studying for all week. I don't want to be that person. I just want you to find what I've got and then fix it, as much as you can today,
Exactly. Exactly. And I think that for non-practitioners who might be listening, uh, if you go into a practitioner and they do the same thing every time, you know, even if you're like, well, I always feel better for a couple of days afterwards, but it's just not making lasting results. It's like, yes, it's because they're doing the same thing every time. They're just assuming you're the same person every time. And they're not adapting to how you've adapted. First off, their treatment should change something in you so that they don't have to do the same thing every time. Not that we won't look at, won't evaluate the same way, have a set way of looking at people, but that the treatment shouldn't be the same every time. There are going to be different aspects of it that need to be treated at different times. Sometimes it's going to be fluid flow. Sometimes, I had a patient kind of say, well, we spent the whole time I came in for my left knee and you worked on my right hip and my diaphragm and you worked on this, but you never even touched my left knee. It's like, right. We can't always, we may not even need to teach the part, touch the part that's causing pain or has pain, not causing pain, is having pain. That may have nothing to do with it. Or it may be something we're going to get to, but we're going to have to get to it sooner, at some point in the treatment. The thing is there's a whole list of things or a whole bunch of things that have to come before that. Now, I did have one patient, she was coming in and she had multiple, she had plantar fasciitis of long-standing nature, but she was also having these migraines and she was also having these other problems. And, in going through and treating her, I was treating for half an hour and we were only getting, part of the way through all the things that she wanted to address. And she kind of got frustrated. I was like, "Oh, I'm going to go do something else." I'm like, "Yeah, that's awesome." Um, but then, of course, she was going to see this other person who said nobody can now touch this patient's neck. It's like, look, that's not how I work. And so what I then told her, I says, well, if you feel like we're not able to address the things in the time I have, then you need more time. So you might have to have like an hour appointment. Um,
hmm
not all, we don't always have time for that, but certainly if the patient looks out far enough in advance. So when people don't feel like their needs are being met, talk to your therapist and say, either you're doing the same thing all the time and I don't want the same thing all the time, or I need more time so you can get through everything. Patients have to feel free to speak to their practitioners and say, here's what I feel I need.
Yep.
I mean, a
Yep.
person shouldn't sit back and not tell their therapist or their doctor or whomever, hey, I don't feel like I'm getting out of this what I want. What do you have for that?
Yeah. It's got to be a team thing.
Exactly. So I highly encourage patients to kind of feedback, but also to, like, oh, you didn't touch my knee, because there was a bunch of other things we need to treat in order to ever even get the knee to feel better. But B, because we ran out of time, that may have been on the docket to do something about, but it just ended up, that would have been the 45th minute and we're only here for 30 minutes. So,
hmm
and so patients need to understand those things. Um, Therapists need to understand those things. Everyone should feel free to speak about that, but also be educated to say, "Hey, I noticed you didn't touch my knee, and I know there's probably a lot of things, and I've gotten this from patients. I understand there's a lot of other things, but are we ever going to touch my knee?" Say, "Yes, we will touch your knee." Um, so yeah, it can be a little, it can be a little hard. These biomechanical problems sometimes they're long-standing and very complex, and it just takes a lot of time to get through them. So patients should feel free to ask, but also, you know, discuss that with their therapist and understand it may just be that you need more time and you have to demand that of your therapist. Say, look, I need an hour. I know you normally do like half hour or 45 minutes or whatever, but I need more time. Of course, that's all about cost, but you can't have 100% of things treated in 29 and a half minutes,
Yeah. Well, and that's
This
one
is
thing
also, I was just going to chime in and just say that that's good for practitioners to anticipate too.
Right.
clients are going to have, issues, and you need to think about how to address them. So
Right.
this is good stuff to get, good things to consider.
Right. Exactly.
One thing that I tell people when they first come in is I was like, okay, well, you've already been to everybody. By the time they see you the first time, they've been to everybody, right?
Right.
And those people almost always just go to the place that hurts and they wail on that spot. And so I think, well, that's the last place I'm going to go because these people aren't dumb, right? If it's a knee thing and they've beaten on the knee and treated all these things in the knee, then they already did my job for me. It's not a knee problem. It's not starting in the knee. And so I just try and explain to them, go, okay, well, I already know. I mean, you've already had this done. Let me look for other things that also going to put it there. And maybe it's not going to fix the entire knee thing today, but whatever I do fix today, I want to stay as much as possible. And I already know that these other people have tried to do it directly where you hurt, and that didn't work. So this also feeds in here, and this also feeds into here. Let's try working there, and then we'll give you some time to take those out of the equation and see if the knee feels better. Give it some time, but let's try something different than what you've had, right? If nothing else.
Exactly.
So.
Exactly. Yeah. So it's good for, and then as you said, Brent, it's important for practitioners. And I actually need to put something on my website and say, hey, if you don't feel like I'm able to address all of the needs within this one time slot, please let us know so that we can accommodate that and say, we will give you 2 time slots. I don't have a lot of those in my schedule. However, if we can plan for it, if you communicate that need, then we're here to help, and we can't help unless we understand, we're trying to help in the period of time we normally help, but sometimes that's just not enough time.
Mm-hmm.
And patients should
Yep,
feel free.
Go ahead. I just barely opened up an hour slot, and it's double my half-hour slot time. And then I've had some people take that one, and I've had to call them and say, no, you can't tolerate an hour. That's not for you. But I do have a lot of people, like right now, I have a lot of end of the year surgeries. They paid up their deductible, they're getting their surgeries, and we do need a little bit more time because they are more tender, or they're in a wheelchair, or they're on crutches, and they've got to have more time moving and stuff. And so we go, okay, well, for certain of those, they can take those if they want them. But
right.
but yeah, you don't want to be you just don't want to be spinning your wheels in the same mud.
Right, exactly.
You want to fix whatever you can do, have that be as long lasting as possible. So you're not always fighting that same thing.
Yeah, exactly. So, and so much of this is for us as practitioners as well to understand, like, hey, sometimes patients need more time. I think that's awesome that you've already made something like that available in your time slot, saying, hey, if you want an hour, I have not advertised that in the past, but I think I need to put that out there that if you feel like you need
this is brand new for me.
Right.
I'm surprised how many people are taking it though, but you're like, oh, that was way to plan ahead. And then they plan the time, and we're more relaxed too.
Exactly.
But for the most part, I can't, most people I treat can't take that much treatment.
Yeah. Then that's why I think I limit mine to half an hour. And then when people do say I really want an hour, you're like, really? Okay. I mean, because we're trying to do our best and make it the biggest change we can in the amount of time that we have. So, but again, sometimes.
And not over-treat. That makes things come undone.
Yes, exactly. Exactly. Okay. Yeah. Well, I think we answered those couple of questions. She had some other questions which lead into some interesting things like bilirubin, et cetera, et cetera. Bilirubin may be easier, treat the liver, treat the spleen. But we need to get deeper into that one next time. So this time, the actionable item for people now is to understand, like a child that thumb sucks or has one of these, a problem like that there's a reason for it. There's a biological need for it. That child is doing something. So for example, I was speaking to one practitioner and they said, look, I've had a child, he's 12. He's been a chronic bedwetter, had all sorts of problems. I've done some stuff. I mean, I certainly went through, I think you have to look at this, you have to look at this, you have to look at this. But, understanding that there's a biological reason for this. And if we can find that, then we can be far more successful in treating the patient. And that there are treatments for that. There's definitely a biomechanical treatment for bedwetting, for thumb sucking, for some of these other things that, like you said, that people are getting psychological counseling, when really maybe it's just that the brain needs that feedback or needs that stimulus or needs drainage, which goes back into
and sometimes it's pharmaceuticals too, like ADHD drugs or whatever. And you're like, hey, maybe if you take the pressure off, the brain wouldn't have such a hard time.
Right.
The body wouldn't have such a hard time,
Right. And then our job is to make sure that those work the most effectively for the patient, right? Not that we say, oh, never do that. It's like, well, there's a time and a place for everything, but how do we make it work better? And then that feeds right into our gentleman with the partial knee replacement, that you don't wait. You get in there as soon as you can and begin clearing out fluid, help guide the immune response, and get rid of inflammation, help oxygenation, which sounds crazy, but you have to get in there right away. And that doesn't mean go and damage what has already been done surgically. That means assist what's been done there surgically. Okay. So I'd highly encourage people to look for a therapist that can listen to their needs and wants and help find a solution.
Yep. Talk things through.
Exactly.
All right, Neal, thank you so much.
Thanks, Neal.
Yeah, that was awesome. Thank you guys. And thank you guys for being here. And
Yeah. Oh, one quick thing before we go. So you mentioned a couple of classes that you taught these things in. One you said was the Arbuckle class, and then I think you said another one was the pre and post surgical knee and hip class.
Correct.
I can't remember if you mentioned any others.
For these two questions, those were the big answers. Those are the big two classes. We've also, we've taught a vagus class, and it's advanced vagus. Also the T2 ring, which is sympathetics and immunity. So the immunity, there's several classes that have immune questions and immune treatment contained within them. And you think, how do you treat individual cells running about the body doing things? Partially through the nervous system, partially through the endocrine system. So you can help that body do that. So there's various classes that have that in them as part of the teaching curriculum.
Cool. So I just wanted to bring that up in case those who are watching, want to dive deeper into this, that those classes are available to take, and we'll put a link to them in the notes for the show.
Okay. Sounds good.
For the recording. Okay, Neal, thank you so much.
All right. Thanks, Brent.
Thanks, Neal.
Thanks, Autumn.
All
right.
Bye.
Bye.
See you, bye.
Thanks for joining us on another episode of OsteoSignal with Neal D. O'Neal. For more information, please visit PursuitPT.com or PursuitPerformanceTraining.com. Our music was written and performed by Sky Toes. Copyright 2026 by Neal D. O'Neal.